Okay. Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon, everybody. Greeting here from Egypt. I'm happy to have Professor Sukin Shah. He is Associate Professor of Orthopedics in Thomas Jefferson University. He's a pediatric orthopedic surgeon. He's one of the best 17 pediatric orthopedic surgeon in USA, and this is a nomination he got in USA since 2014. He has more than 100 research, and he wrote more than 25 book chapters. He is innovator, researcher, and he is a key opinion leader in the field of spinal deformity in the SRS society, and we are happy to have him between us here, delivering and giving us his experience, in particular to the early onset scoliosis cases and in cases with osteogenesis imperfecta and cases with neuromuscular scoliosis. I'd like to have here in the panel as well Professor Yusr Al-Hawari. He's a pioneer in deformity surgery, and we have Dr. Ala Azmi from Palestine, and we are waiting to Dr. Hazim Al-Sibai to share his experience as well in the panel, and maybe sharing in asking when he joins the meeting. I'd like to thank you all for participation, and Suk, can you start your interesting talk? We are happy to have you between us.
Great. Well, thanks very much, Mohammed. I'm sorry that I can't visit Cairo this year, and I hope everyone's coping well with the global pandemic, and God bless everybody.
Inshallah, yeah.
Start out with the early onset spinal deformity. This first talk is about looking beyond just the curvature and all of the issues that we have to deal with early onset spinal deformity, and then we'll end with the operative treatment of early onset scoliosis in the contemporary 2020 period. So the definition now is a little bit different. We know that early onset scoliosis previously used to be the onset before age 5, but now we've upped that almost to age 10. The point is the treatment of these children is very challenging because the natural history is that they get progressive thoracic deformity, pulmonary compromise, and the traditional methods of early fusion are not ideal. We need to preserve the growing spine, the chest wall, and preserve lung function well into adulthood. We can divide up some of these etiologies into infantile idiopathic, congenital, neuromuscular, syndromic, and other pathologies. Professor Demiglio from France told us about growth of the spine. This is a chart of a boy's spinal growth from T1 to S1, and you can see that from birth to 5, they grow 10 centimeters in the spine. Then there's a relatively slow period from 5 to 10, and then after 10, during puberty, they have another tremendous growth spurt. And you can figure out what a fusion will do to sacrifice growth of the spine. This has actually been updated recently by Jim Sanders. He says that spinal growth is very rapid during the growth spurt, is a very tight band, even for girls and boys during peak height velocity, and there's very little variability during that time. Furthermore, with the growth rates during childhood, during the growth spurt, and terminal growth, have been revised upward. These are higher than they were reported previously with Demiglio. And these are very important growth rates to understand, because if we prescribe treatments like growth rods or casting or fusion, we have to understand what the sacrifices and the pros and cons of preserving growth or stopping growth in the spine will be at that time. And we can calculate growth very easily because the thoracic spine grows 62% of the length and the lumbar spine 38% of the length. And so each of the vertebrae grow 1 centimeter per year in the lumbar, 0.7 millimeters per year in the thoracic in childhood. And then you can see how those growth rates virtually double when that child becomes an adolescent. But we can't forget about the fourth dimension of growth of the spine, which is volumetric growth of the lungs. And you can see here from 10 to 15 years old, there's a doubling of the volumetric growth of the rib cage, which is very important also for pulmonary function. So with that background, the concern about early onset scoliosis is this. Life-threatening health risks result when significant curves develop in young children. They get thoracic insufficiency syndrome, which is the inability to support respiratory function when you're an adult. because the chest wall and lungs are very small. So we have to preserve spinal and chest wall growth during this treatment. The natural history of early onset scoliosis is generally quite poor. Michael Vitale compared children with early onset scoliosis to those who have asthma, juvenile rheumatoid arthritis, congenital heart disease, and found that patients with early onset scoliosis generally have a poor quality of life, especially if they've been fused early, because they have a short spine, more pain, and poor respiratory function. The dangers of ignoring growth of the spine are well known. We know that an early fusion leads to decreased pulmonary function, up to 30 to 40% predicted, and that's not compatible with adult life. That's what thoracic insufficiency syndrome is. John Emmons and Day also showed that congenital spine patients who are fused early generally do not have good pulmonary function. The best data to date is that by Laurie Carroll. She studied less than 30 patients, many of them congenitals. They all had early fusions. The pulmonary function was not good, but the two most important correlations with poor pulmonary function was the extent of the spine fused and how high or how proximal that fusion went. So the next few slides are just data from her study, showing that as you increase the amount of thoracic spine fused, the pulmonary function goes down. As you go more proximally in the spine, T1, T2, pulmonary function goes down. Your best bet is to try and preserve thoracic height. And as you get the spine to 22 centimeters of length from T1 to T12, they generally will have near normal pulmonary function. So our objective with any treatment for early onset scoliosis is to preserve spinal growth and achieve thoracic height as much as possible. And if we get to 22 centimeters between T1 and T12, we can generally expect good pulmonary function. So the goals of treatment are to control the curve, optimize pulmonary function, preserve spinal growth, motion if possible, limit the number of complications, and facilitate care of the patient. All of that comes together to an improvement in quality of life for an otherwise pretty debilitating spinal condition. So what's the workup? It can be different from any of these etiologies. Are they in fact idiopathic, or is there a congenital or syndromic deformity? What are the other medical problems that go along with these conditions? What are the other orthopedic problems that go along with these conditions? And how do we evaluate their pulmonary function and spinal cord structure or dysraphism? We need a systematic approach. So they need a preoperative workup, including standing x-rays if they can stand, an MRI of the entire spine, a CT of the spine and chest to look at the congenital anomalies, look at 3D reconstruction, especially if some sort of resection procedure is planned, and examine the neck for any congenital fusions, the hips for hip dislocation, the knees for congenital hyperextension, and the feet for things like club feet or vertical talus. So you need consultations from multiple medical specialties too: cardiology, genetics, nephrology, maybe even urology for other genitourinary concerns. And at a family conference, we have to discuss the expectations. What is the plan? Does the family agree? Sometimes they don't understand that we would like to preserve spinal growth. Sometimes they favor having early surgery, but we have to plan that out in a very systematic fashion. And when you do this type of surgery, you need your best team, because there are significant complications that can occur during surgery, such as excessive bleeding. Sometimes these children are very difficult to intubate or get IV access. Sometimes they need specialized instrumentation. And you need very good spinal cord monitoring for all of these cases. If we have to establish a diagnosis of specific syndrome, be familiar with that syndrome. What other medical problems do they have? And always get the genetic people involved to get a true diagnosis. Because syndromic scoliosis can have all kinds of problems: poor bone quality, very stiff osteoporotic spine. Bracing doesn't work for these conditions. These children bleed more, they have poor neuromonitoring signals even at baseline, and they're medically complex. So they need to be optimized for surgery to prevent complications. Many of these syndromes are familiar to you: Marfan syndrome, Larsen, arthrogryposis, NF, and each of them have their own specific issues that are very important to recognize prior to treatment. These are syndromes associated with a small thorax and stiff curves. The reason I bring these up is because many times in these syndromes, we would like to grow the spine and improve their pulmonary function as much as possible before adulthood. These are syndromes associated with sagittal plane reversal. That means instead of thoracic kyphosis, they have thoracic lordosis, or instead of lumbar lordosis, they have lumbar kyphosis. And we need to pay attention to the sagittal plane as much as the coronal plane in many of these syndromes. And these are syndromes in which the bone healing is very poor, and we might have to use very specialized instrumentation or techniques, or even BMP, to facilitate healing so they don't have complications. And these are syndromes that have very important implications for the cervical spine. We need to do a cervical spine wake up and be very careful with traction or intubation, or sometimes treat the cervical spine before the scoliosis below. So very important things to review. So what are our treatment options if we want to delay surgery or avoid surgery? We can use casting. Casting is re-emerging as a treatment for early onset scoliosis. And I understand that in some countries it's very hot and casting is not tolerated by our patients, but it's a very important technique to use when possible. It was first espoused by Contrell and Morel when they used derotation and flexion techniques. But the best contemporary article is that by Jacques Destoux and Jim Sanders, showing us the technique described by Mehta earlier in England to allow windows and a derotation method to assist with casting. Her very important article in the British JBJS described her lifetime experience of treating hundreds of children with early onset scoliosis. She had this theory that scoliosis could be reversed by harnessing the vigorous growth of the spine. And those treatments, those children who were treated early, who had smaller curves and who had an idiopathic type of etiology, were cured with casting. Some kids who were referred late or had syndromic diagnoses only had a delay of treatment. This is the type of cast we use at DuPont. You can see there's an anterior window because these children breathe with their belly and chest, and then there's a posterior window for derotation. They handle this cast very well. It does not delay their development, and initially they might be fussy, but they learn to adjust to this cast very easily. We change the cast every 3 to 4 months, and after perhaps a year, if the curve is reduced, we can go into a brace. This is a child who was 2 years old with Prader-Willi syndrome. Very severe curve, 60 degrees. This is the first cast. And then this is infantile idiopathic scoliosis. You can see that the curve is corrected slowly with time. And after 9 months and 3 casts, we changed him to a brace. And then ultimately the curve resolved. In general, the studies out of the United States and North America will tell us that casting can be used as a very good delaying technique. And in certain early onset patients who are referred early, we can get a cure. But most of the time, we're trying to delay treatment until growing rods might be more successful. We would not like to operate on children when they're very young. The best results are in those kids with who are less than 20 months old, less than 2 years old, with curves less than 60 degrees. There are issues with intubation that you need to be aware of, and during casting, sometimes the child can undergo some complications, so you need to have a good anesthesiologist who's comfortable with that. The new data suggests that delaying surgery is the best technique. You have a decrease in complications in older children, better soft tissue for covering the implants, you get better weight gain. They're generally more healthy when they're older rather than when they're 2 years old. So we would like to delay surgery as long as possible because the complication rate is lower. This is a child with early onset scoliosis, thoracic curvature almost 60 degrees. You can see some kyphosis in the sagittal plane. What are some strategies now operatively if bracing or casting has failed in this child who's 6 or 7 years old? We can distract posteriorly with growing rods or the expandable rib. We can do guided growth like the Lukey trolley or the Schilla technique, or we can slow anterior growth with some sort of vertebral body tethering or neurocentral growth arrest. Like I said before, MRI scan is mandatory in all of these early onset scoliosis patients. We find up to 25% incidence of spinal cord dysraphism, like a tethered cord illustrated here, or a Chiari malformation, or syrinx. And it's very important to recognize these issues prior to surgery. This patient then went on to have a dual growing rod. You can see this is an old case using a tandem connector and dual rod technique with crosslinks, fusion at the anchor sites proximal and distal, and not very good control of the sagittal plane, but there was a reduction in kyphosis. At 4.5 years, you can see that the rods have expanded. She had multiple surgeries every 6 months to keep up with growth. This was open distraction through the tandem connectors. And over time, she had an increase in her T1 to S1 height of more than 8 centimeters. At skeletal maturity, she's doing fine, and we did not have to revise to a final fusion. This is a child with neurofibromatosis type 1. You can see the cafe au lait spots, the thoracic lordosis, and severe coronal decompensation. He also failed bracing. You can see his x-rays here. Initial implantation of dual growing rods followed to near skeletal maturity. Sometimes we have to revise these patients to final fusion, but we now have a growing body of patients in whom, if the rods are stable, the deformity is well controlled, and there is no implant failure, we won't revise these growing rods. Overall, the results of growing rods are quite good when compared to the natural history. We would like to lengthen these rods every 6 months, dual rods, submuscular implantation, achieves near normal predicted spinal growth of these children. However, the complications are quite frequent. You can see that the growth rate does approximate that espoused by D'Amiglio, about 1.8 centimeters per year. We're trying to drive the spine to continue growth. But the results are quite variable. They're applicable for various curve patterns. You can have a pelvic fixation option for neuromuscular curves, and you can control kyphosis, as we've demonstrated in sagittal plane. Here, we were able to show that the growing rods can establish near normal sagittal plane parameters. In those patients with severe kyphosis, we're able to reduce it. In those patients with severe lordosis, we're able to increase the kyphosis without a significant issue of proximal junctional kyphosis, but that does need to be recognized. You can revise proximal junctional kyphosis later during the final fusion by going up a level or two. The number of lengthenings doesn't have anything to do with deterioration of this patient in the sagittal plane. And like I said, the complications of growing rods are quite significant. You can get infection, rod breakage, anchor failure, proximal junctional kyphosis, and then a stiffening of the spine and a failure to achieve lengthening. In our study showing in the growing spine study group, we had 58% of the patients had at least one complication. Many of them had more than one complication. The complication rate increased by 24% with each additional lengthening. So the more surgery, the more complications. We also know that children with many surgical episodes have significant psychological trauma, much like post-traumatic stress disorder, anxiety, and learning problems when exposed to many different surgical procedures. We also know there are issues with repetitive anesthesia, hyperactivity, attention deficit disorder, and cognitive learning issues when children are exposed to anesthesia many times at a young age. So how do we limit the complications? How do we limit the number of surgeries? This is a patient with an MRI scan showing severe kyphosis. She had a thoracoscopic anterior release, halo gravity traction to partially reduce the deformity. And here we implanted sliding screws like the Schilla technique. So there's an apical fusion in the middle, sliding screws proximal, sliding screws distally. And the postoperative appearance shows a nice correction. And now the patient doesn't need additional surgery because as the spine grows, the screws can slide along the rod. This is another case, 8-year-old boy, similar construct, apical fusion, proximal and distal fusion. You can see the correction here. And another way to avoid repeated distraction is the new magnetically driven growth rods. With here, there's internal lengthening, no more surgery. Adjustments are performed in the clinic rather than the operating room while the patient's awake. The early results were done in Hong Kong, Egypt, and in the UK. And each of these reports in many different journals show very good results in the early periods. You can see this article by Dr. El-Sabai and Nordine showing early results of the remote controlled growth rod were quite good. This was the first case in the UK with a single rod construct, juvenile scoliosis, showing very good control of deformity, and then subsequently revised to final fusion at age 12. This was our first case, a 2-year-old male with idiopathic scoliosis, brace and casting. When that became intolerable and the curve increased at age 7, we switched to growing rods, the magnetic controlled growing rods, and these are his initial films and subsequent lengthenings achieved over time. So this became the next generation of growth sparing techniques. Traditional growth rods in the United States have gone down rapidly with rapid adoption of magnetically controlled growth rods. Good correction of the spinal deformity, and during the early distraction period, we do get good length gains. We can do the lengthening in clinic and verify the rods have undergone lengthening with ultrasound. So the timing of surgery in general should be early. Surgery should be avoided. We want to do non-operative treatments until they have failed. If the curve progression has increased to greater than 60 degrees, sometimes growth modulation techniques can be entertained with operative intervention. But sometimes in certain conditions like spinal muscular atrophy, maybe we want to do an early fusion instead. Late surgery is when the complication exceeds the growth rate, the spine is stiff, and preferably after peak height velocity, we can revise to a final fusion. But do we even need to fuse at all? Surgeon consensus is that generally growth rods are good for curves greater than 60 and age around 7 or 8. And what are the areas where we're currently studying? What are the gaps in the evidence? Well, when is lengthening over? How frequently should we lengthen? Now that we have growing rods, we can lengthen every month, every 2 months, every 3 months, and there's a lot of variability in that. When do we use spine-based anchors versus rib-based anchors? When do we include the pelvis? And when should we, if at all, do a final fusion? So I would say that in the last 10 years, the management trends in early onset scoliosis are these. Delay fusion whenever possible with casting. Later implantation of growth modulation is better. Nutritional and height gains are important in that early childhood period. We want the children to get healthy before we do surgery. And we want to optimize those patients who are very frail, osteoporotic, or malnourished. If we're doing surgery, we would like to increase T1 to T12 length as much as possible, because that's the best correlation with pulmonary function. Complications are reduced with growth rods, especially submuscular implantation rather than subcutaneous, because that muscle layer guards against infection. We want to decrease the number of surgeries for lengthening. So we can use instrumentation techniques that don't involve frequent surgery, screws that are sliding or magnetically controlled rods when available. Thank you very much.
Thank you very much, Suk. Very comprehensive, illustrative case. So, any comment from Dr. Yusri and Dr. Ale, our panel? And we are happy to have any questions from the attendees as well.
Sukin, thank you very much. Great presentation. We heard last month that there were recall of cases done by Generation 2 magnetic rods. How true is that?
It's very true. So there was a recall by the FDA in the United States of the Magic X rod. and then subsequently there's been a recall in the United Kingdom and Ireland of the same rod. You know, the initial rod, Generation 1, which was available in Egypt and UK and Hong Kong for probably now 10 years, had a problem with the distraction pin that was breaking. So they made that better. The newest rod had replaced the O-ring and had this end cap welded on. It seems that in 1 to 2% of the cases, that end cap is dislodging and the rod fails to lengthen. Bodily fluids can get inside the mechanism, which may interfere with the lengthening process. And then the metallic debris can leak out of the implant into the body, which we don't know the long-term effects of some of those rare earth minerals or titanium debris. So as of, I believe, March, we were not allowed to do any more implantations of the magnetic rod until they fixed this problem. And now with the COVID pandemic, we're not doing any elective surgery like this anyway. So that'll give some time for the company to hopefully correct the problem. But we are not revising rods that seem to be functioning well or look good on the x-ray. You can tell on the x-ray if the end cap is dislodged. And if so, they would recommend revising that rod to the earlier generation.
Thank you, Suk, for the presentation. Very nice presentation. There is something that is always annoying the surgeon who deals with early onset scoliosis, which, as you said, is the pulmonary function, which we always think that this is a very important thing to manage. It's the main issue for management. But considering that that there is Greg Redding was talking about the pulmonary tissue, which is not appropriate. And this was a major problem. It's not always depending on the spinal height or the fusion or the levels. And also with Kit Song literature about talking about many cases that had worse results after putting the growing friendly rods. So how can you deal with the family in the beginning for the assessment of the pulmonary function and telling them what they will have in the future? Especially in my experience, you know, it was a little bit embarrassing that after doing the surgeries and after the child becoming 12 years of age, I get them to the pulmonologist to do pulmonary function and they say it's bad. So the family will look at you, what did you do?
Yeah, so that's important to manage the expectations. So first of all, I think with Greg Redding's work is excellent, and we look to him to understand what's the best technique for assessment of pulmonary function and maintenance of pulmonary function. I think, you know, you mentioned Kit Song's data. That was mostly with Vector. I think Vector use in the United States is very limited now for certain syndromes like June syndrome and costospondral dysplasia. But we now prefer going to spine-based constructs because they seem to be have a lower complication rate. Now, with that being said, I think first of all, it's difficult to assess pulmonary function in kids. They can't voluntarily comply with spirometry. So we have now dynamic MRI, or we can do lung scans with low radiation to understand lung volume and lung respiratory mechanics with the diaphragm and rib cage movement. If we want to create a more compliant respiratory function, avoiding rib-based fixation is probably better. And so I think we have to explain to the family that this is a very complicated problem, and we're doing our best to at least preserve pulmonary function. If we get an increase in pulmonary function, that would be desirable, but not always possible.
We have a question here from Dr. Ahmed Marziban from United Arab Emirates. Dr. Marziban, can you deliver your question or your comment?
Okay, thanks a lot.
Dr. Ahmed Marziban.
Thanks a lot for this nice presentation. Just a question regarding the casting. The window, the posterior window over the rib hump, it is just to avoid the pressure sore of the hump against the cast, or it has a role in rotation?
Actually, yes, the posterior window is not on the convex rib hump. It's actually on the concave depression, because the derotation maneuver is actually using the convex rib hump and ribs to turn the spine. And so that window allows the concave ribs to fall out into that relief. So that's not to alleviate any pressure problems or anything like that. In fact, it's the opposite. We're creating a relief in the cast so those concave ribs can rotate out. I'm sorry that I didn't explain that.
So usually or always the window is opposite to the rib hump.
Correct.
Okay, thank you.
We have a question from Dr. Mahmoud Mahmoud. He's asking about the pelvic obliquity. When it is associated with scoliosis, what is your recommendation in early onset cases? I think he means that.
Yeah, I think if we have to look at the hip issue. If there's a dislocated hip, I think it's important to level the pelvis, because a hip reconstruction is likely to fail again if there's a severe pelvic obliquity, especially if the hip is on the high side. So that's an important consideration. If the pelvic obliquity is interfering with sitting or with ambulation, I would prefer that we do pelvic fixation. However, pelvic fixation in an ambulatory child is okay when indicated, but may interfere with their sagittal balance and may tip them forward. We found that to be true for sure with Vector and pelvic fixations with the Dunn-McCarthy hook. I prefer screw fixation to the pelvis when necessary, only in severe pelvic obliquity. Many times I've avoided initial fixation with growing rods and then done the pelvic fixation at the definitive fusion when we do the revision from growing rods to final fusion.
Okay, another question from France, Dr. Samer Moussa. He is asking about hemivertebrae. You recommend for early onset scoliosis that you are in the era of delayed intervention by doing casting, then at the age of 7 we may go to the rod lengthening, but he asking about the hemivertebra. Is it the same strategy or it is different?
No, isolated hemivertebra, casting or bracing doesn't work. We would follow the child at 6-month intervals for a resection plan if the congenital curve is progressing or it's creating a compensatory problem in the non-congenital anomaly, or if there's a severe coronal balance problem. I don't like doing that surgery in babies or 2-year-old patients. I like to wait until the bone quality is better and we can use better implants. So I like to wait until the child is 4, 5, 6, 7 years old in order to get very good fixation. And that's a good indication for early fusion because it's a very small segment of the spine. So resection procedure, anchors 2 levels above, 2 levels below to get very good fixation, control the sagittal plane if there's kyphosis, and then follow that child to skeletal maturity. And usually that might be the only surgery they need. Sometimes in the future though, there could be adding on phenomenon. They might need a secondary surgery before skeletal maturity to correct everything else. So it's important if you're doing that hemivertebral resection to follow the child until maturity, because you might want to tell the family that another surgery might be possible later.
Okay, Dr. Yusri, do you have a question or something like this?
Yes,
Dr. Yusri?
The law of diminished returns, when does it happen in your experience? After how many lengthening?
With traditional growing rods, it was usually after the 6th or 7th lengthening. And so if you extrapolate that out, it could be at 3, 4 years. With the magnetic rods, we're seeing that the spine does get stiff a little sooner than that. And whether that's because the magnetic rods don't deliver the same force as open distraction, we don't quite know. But we're seeing sometimes you can lengthen the magnetic rods even after 2 years. And so you can continue lengthening up to 3, 4. We have a few children that have had successful lengthening up to 4 years with multiple episodes, 17, 18 lengthenings of very modest 2-3 millimeters each time, and looking at 1.5 centimeters each year. We've had excellent successes, and then some children don't get the same benefit. And sometimes after 2 years, 2.5 years, we have to change out the rods for new rods. So I think the technology is going to continue to improve. I still like the fact that we don't have to do surgery every 6 months. But I wouldn't say that the magnetic rod is magic. We have to also have realistic expectations about what that device can do.
So that means
We have a question.
the honeymoon is the 3 years, I would say.
Yeah, that's a good analogy.
We have a question from Dr. Ahmed Shawqi from Germany. He is asking about syndromes with lumbosacral hyperlordosis. Any recommendation for management?
Hyperlordosis, yes, that's a challenging problem.
Yeah.
Occasionally, in older children, we've done an anterior release to shorten the spine in the front. Complete discectomy all the way to the PLL, and sometimes even a wedge resection of the body so that we can shorten the spine anteriorly and control the kyphosis that way. Because sometimes posterior surgery is not enough when the spine's very stiff, and sometimes in severe myelo, the paraspinal muscles migrate to the anterior part of the spine and aggravate the problem. So I would entertain anterior surgery for those very severe lordotic children. And one way to tell if it's very stiff is to lay the child supine and flex the hips. If the lordosis doesn't get reduced, then the spine's very stiff and you might need anterior surgery. You can also sometimes palpate the spine through the abdomen. And if it's very superficial, then you might need anterior surgery. But if the lordosis is flexible, then you can do posterior surgery, usually with multiple Ponti osteotomies to distract in order to decrease the lordosis, and then use reduction screws to pull the spine back. Typically, they will need pelvic fixation also because there may not be an opportunity to get distal fixation enough levels below the apex of the lordosis.
Okay, we have another question from Dr. Celestine Maduka from Nigeria. He is asking about the role of casting in idiopathic scoliosis. What is the target cup angle in correction?
Well, that's difficult to say because I don't. You shouldn't use a number as an indication for treatment or for resolution, except when we looked at the consensus study, it was like 60 degrees seemed to be when everyone wanted to act for surgery. As far as initiating casting treatment, if the Cobb angle is greater than 35 degrees, the rib vertebral ankle difference is greater than 20 degrees, and the child doesn't have any contraindications to casting, then I would do it. And the earlier you start treatment with casting, the better. When the Cobb angle is reduced to 15 degrees, then we switch to a brace. The initial casting x-ray will usually tell you if casting is going to be successful. So if the spine is flexible and you get a good correction of greater than 50% on the first cast, I would continue with casting for up to a year, telling the family that we would like to see if we can change to a brace after that time.
Okay, Dr. Muhammad Sulaiman from Egypt, you would like to ask a question? Please go ahead, Dr. Sulaiman.
Yeah, thank you so much. My question is regarding the intraoperative spinal monitoring. As there is, sometimes it is difficult to detect any form of intraoperative spinal monitoring in patients of neuromuscular scoliosis due to inadequate somatosensory evoked potential, and in these cases we must rely on Stagnara wake-up test, which is sometimes also it is difficult to interpret in these patients. What do you recommend about that? Thank you.
Well, I think it depends on the neuromuscular etiology. So a child with cerebral palsy who has had a severe brain injury and a lot of cortical dysfunction, I agree, difficult to get transcranial motor evoked potentials, which would be our preferred method of monitoring in all cases. We think that transcranial motor evoked potentials are the most accurate, most sensitive, and most specific for spinal cord injury during spinal deformity correction. The somatosensory evoked potentials delay. They may not be as sensitive, and I don't think they're adequate. But in certain conditions, you're right. Sometimes all you can get are some somatosensory evoked potentials. So if a child is non-ambulatory and has no purposeful movement of the lower extremities, and we do not get baseline signals in the operating room, then we won't monitor, because sometimes bad information is worse than no information. I'll discuss with the family that we weren't able to get spinal cord monitoring, we would like to proceed with the surgery in any case, and explain to them that if there is a spinal cord injury, their child may have a bowel or bladder problem and may lose protective sensation. Those are two very important things that can be lost even in a non-ambulatory child, which would increase the burden of care. I agree. The wake-up test is not possible in a child with cognitive deficit or who doesn't have purposeful lower extremity movement. But we would proceed with the surgery anyway if this curve is severe. We think there's going to be an improvement in quality of life with correction of the spinal deformity, but explain to the family that they might lose bowel or bladder continence and may lose protective sensation. Generally speaking, unless the deformity is very severe, we find that the rate of neurologic deficit in these patients is quite low.
Suk, I'd like to ask you about regarding the investigation. You highlighted the need of plain X-ray, CT, MRI, and these are really young child. And as you know, of course, exposure of CT, for example, is hazardous for their, and the potential may cause some problems for them in the gonads, in the breast, and so on. So when to ask for the investigation? For example, in adult, MRI is a preoperative investigation. In your children, in your cases, early onset scoliosis cases, what is the first investigation you ask? When to ask for CT, when to ask for MRI? Is it a matter of team work decision to investigate, or it is your decision? Kindly highlight this.
Those are great questions. Generally speaking, it would be when we wanted to proceed. Obviously, we need to have anesthesia involved for young children in the MRI scan. And sometimes we even ask our neurosurgery colleagues, do you think it's important to get an MRI scan to check for a Chiari? So I'll say this, I agree with the CT scan. We do not do CT scans on young children unless there's an operative procedure like a resection considered. Because the hemivertebral resection is very important to understand the three-dimensional anomaly and make sure the posterior structures correspond with the anterior structures that you actually want to do the resection for. We'll do a limited window, low-dose CT, and when it's done in a spiral 64-slice scanner, there's no anesthesia involved because it's so quick that the child doesn't move. MRI does require anesthesia or sedation. And if the child is otherwise completely idiopathic, and we are confident that there's no neurologic abnormality or no syndrome, then we will delay the MRI scan until the child's a little bit older. Usually, we'll do the casting and then do the MRI at the same anesthesia in order to limit the number of episodes, as long as we think it can be done in less than 2 or 3 hours. But if there's a neurologic abnormality, then I won't wait to do the MRI scan. I'll do the MRI scan early because there's an opportunity that maybe some neurosurgical intervention can correct the issue, and maybe the spinal deformity will resolve as well. You've probably seen cases in which there's a syrinx or a Chiari malformation, and if the curve is less than 40 degrees, sometimes the curve will resolve if that is treated. So we want that opportunity, and we wouldn't know unless we did the MRI scan.
Okay, we have a question here from Dr. Ahmed Marziban. You have a question, Ahmed? Dr. Marziban, you are self-muted if you would like to ask or comment.
No.
Dr. Marziban.
I already asked my question. Thanks a lot.
Okay, thank you. So, so the last comment, so please, if you have patient with tethered cord syndrome, and you are decided to do lengthening, cross sparing techniques, whatever you would like to operate and will need for these patients, shall you send them to the neurosurgeon to release this tethered cord, or you proceed for the growing rod instead of presence of this tethered cord syndrome?
We do that surgery simultaneously. So, and the reason is with good neurologic monitoring, we think it's totally safe. We don't necessarily agree that the surgery should happen and then 3 or 4 months later do the orthopedic surgery, because that's 2 anesthetic episodes. So we would do the tethered cord release and then immediately at the same surgery do the growing rod implantation with good monitoring, ensuring that there's been no issue. We have a paper on that from the Growing Spine Study Group showing that with good monitoring, it's totally safe. Subsequently, other authors have also shown that treatment of congenital scoliosis with tethered cord, final fusion, growing rod implantation, with good monitoring, it's generally safe to do those procedures together.
Okay, Dr. Yusri, would you like to comment or ask something?
You mentioned the anterior release in the growing spine. You remove all the disc or just incise it?
I don't typically do an apical fusion in early onset scoliosis. George Thompson did that for a while. He did apical fusion and then growing rod instrumentation. Those patients did very poorly because it did not really help with crankshaft phenomenon. And Pigot's early work, the long-term follow-up wasn't very good. The only reason I talked about that anterior resection was someone asked about a very hyperlordotic neuromuscular condition. But I wouldn't advocate anterior surgery for early onset scoliosis. I think our posterior techniques are quite good. Unless you're following someone without surgery and you want to do a definitive fusion at 9 or 10 years old, then I would say yes. In order to prevent crankshaft, even with pedicle screw instrumentation, we would do a thoracoscopic release, minimally invasively, cut the annulus, take out the disc, and obliterate the growth plate and do an apical fusion there because we don't want to get crankshaft, if we're doing a fusion at 9 or 10 years old with open triradiate cartilage. When we looked at those patients in the harm study group, there was a significant incidence of crankshaft phenomenon, even with modern pedicle screw instrumentation. So if you can do it thoracoscopically, I would advocate for doing that. In the neuromuscular population, when we go to the pelvis, we can do fusions on very young children, T2 to the pelvis, and they don't seem to get crankshaft. I think when we're just doing a thoracic fusion or something like that, when we don't have full control of the spine, that's when we get add-on or crankshaft.
Thank you, Sukso. We are very excited to hear your second talk. It is scoliosis and osteogenesis imperfecta, which is really something we can face, and we are, all of us want to know a lot from your experience in this field. Please go ahead for the osteogenesis imperfecta.
Okay, just gonna minimize this. Okay, so can you see my screen now with the title
Yes.
slide? Okay, perfect.
Yes.
So we have a major center at Nemours for osteogenesis imperfecta. People are coming from all over the US and the world to see our practitioners. And so I've developed quite an experience in the treatment of the spine for these children. And you can imagine that the bone is very soft, the curves are very stiff. And so hopefully I'll give you some tips and techniques in order to help these children. So we know that, I do want to mention that we have this article in the Journal of Academy of Orthopedic Surgery from 2017, looking at all of these issues. So if I go through this quickly, this review article is very good in summarizing the issues with very good references. So if I can direct you to that. So we know that the etiology and pathogenesis of OI is related to the severity of disease. And in the spine, they get compression fractures and then asymmetric growth with age. And so if you have a wedge vertebra from compression fractures and then asymmetric growth on top of that, you can imagine a vicious cycle of increasing deformity, especially during the adolescent growth spurt. It's also related to the type of OI they have. Type 3, which is the most severe type, their mean progression of the curve is almost 6 degrees per year. And 68% of these patients can get scoliosis during their childhood or adolescence. Type 4 also has a significant rate of progression. And type 1, which is the mildest form, may look very much like idiopathic scoliosis. Many of these curves don't progress to need surgery, but should be followed. Bisphosphonates, like pamidronate or lozolindronate, can be used before age 6 and can actually decrease the rate of progression and maybe even allow these children who are treated very early to avoid surgery because you're increasing the bone density and avoiding some of those microfractures. Bisphosphonates before age 6, especially in the type 3s, if they didn't have treatment, they were progressing 6 degrees per year. If they did have treatment, they were progressing only 2 degrees per year. So that was significantly different with bisphosphonates in the severe type of OI. Pulmonary function, we spoke about this in the earlier lecture. is a significant issue for these children with osteogenesis imperfecta, and the quality of life correlates with pulmonary function. So you'll see that as the scoliosis increases, their percent vital capacity decreases because it totally disrupts their rib morphology and respiratory mechanics, in addition to shortening the chest wall and chest cavity, so that it has significant pulmonary function problems. Many adults with osteogenesis imperfecta and severe scoliosis died of thoracic insufficiency syndrome. So if we can intervene early on some of these children, we should be able to increase their lifespan. So spinal fusion for OI scoliosis has been advocated for curves of greater than 45 degrees, and patients with severe involvement may benefit from fusion even with milder curves, may not improve lung volumes, and may halt the respiratory decline. This is some of the early literature. I'll tell you that we're treating curves that are much more severe than 45 or 50 degrees, and sometimes we'll wait until they're a little bit older to do the surgery, much like we talked about yesterday, where we're trying to increase the length of the spine. I don't prefer growing rods for these patients, but sometimes I'll show you some cases where we have used growing rods when the cases were quite desperate or the curves were quite severe even at an early age. Curve progression in adults with OI, not much is known. We know that it can be a significant problem related to bone health. Larger curves definitely progress. If you talk to adults with OI, they have severe back pain. Most of the time it is in the lumbar spine because of the hyperlordosis and pelvic impingement, or rib on pelvis impingement. And they can also get degenerative changes in the discs and facets. Non-operative treatment mainly is observation in these children. Braces are a limited option because the chest cavity is so frail. And the medical treatment is very important. They need to get on bisphosphonates early if they have scoliosis. It can also prep the spine for instrumentation later, and then continued progression in life is lower with bisphosphonates. Historically, you'll know that these results are very poor. The complication rate is high, no correction was obtained. They needed reinstrumentation because the instruments pulled out. You can see that Harrington rods didn't do very well. The correction was only 36%, and half the patients had a complication: excessive bleeding, implant pullout, revision surgery, and pseudoarthrosis. And so many people avoided surgery for osteogenesis imperfecta for more than 2 decades. Well, what changed? Contemporary surgery allows us now to give better care to these patients. We have better medical therapy, we can optimize the bone, and this is related to bisphosphonates, allow us to achieve more secure fixation. The other thing is our anesthesia is so much better. We know that children during positioning for spine surgery can get fractures of their upper and lower extremities, so we're very careful during positioning. They can have airway issues. We now know that they can develop hyperthermia, and we can control the blood pressure and use medications like TXA in order to improve the bleeding and prevent transfusions or massive bleeding during surgery. So we wrote up our experience in the Journal of Spinal Disorders, looking at how we can do this surgery contemporary. We do spinal osteotomies and cut the ribs to make the spine more flexible. We use screw fixation to obtain 3-dimensional control, and we use cement to augment the screw fixation so we don't get implant pullout after surgery. In our series, and this was early, we achieved more than 48% correction, and now in our contemporary series are achieving 55, 60% correction with no loss of correction over time because the implants are now stable with the cement augmentation. Spinal cord monitoring is mandatory, no neurologic deficits after surgery, no implant failures, and now that we are following their quality of life measures, they have a huge improvement in quality of life because they're able to sit straighter, they're also able to expand their chest, and they don't have the rib impingement on their pelvis anymore, so pain relief and sitting tolerance is quite good after surgery. This is typically what you see in the severe type 3 OI. You'll see that the ribs are rolled over the spine, and even the exposure of the spine is very difficult in that lordotic apex where the ribs are in the way. So we cut those ribs, we osteotomize those, and use retractors to gain access to the spine. Here's the characteristic vertebral body wedging of the spine at the apex. Sometimes screw fixation is quite challenging because the pedicles are very sclerotic, small, and you can create fractures. So we use a small instrumentation system when appropriate to get good pedicle fixation. And then this is how we augment the screws. The old way was using jam sheeting needles and injecting the cement and then putting the screw in afterwards. And this is a fluoroscopic view of that. You can see the cement and then we put in the screw. But now the new technique is using fenestrated screws, which allow us to do safe pedicle screw fixation, check the position with an intraoperative CT scan or O-arm, and then those screws that are safely placed, we can use fixation like cement. I only do this at the top and the bottom. I don't do cement fixation at the apex because many of those screws could have a small medial breach that we can't see. So just where it's safe at the top and bottom, and these are really the only screws that we want to protect against pullout. Multiple anchors, that means many screws, maybe some sublaminar bands, and slow reduction, usually 4.5 millimeter titanium rods, sometimes 5.5 millimeter titanium rods in the larger children. But we're not going to get very aggressive with the correction. Slow reduction over time. I also use intraoperative traction to help correct the deformity. And these are some of the post-op x-rays where we get pretty significant correction, and you can see the cement localized to the proximal and distal foundations, because that's where the most stress of the implants are going to be for pullout. And when possible, I'd like to get some correction of the lordosis to kyphosis, because that's a good way to improve pulmonary function on some of these children. This is a 12-year-old female with a 100-degree curve, very stiff. You can see the clinical photos. This is a typical type 3 OI patient. We did do intraoperative traction, not preoperative traction, but intraoperative traction to correct some of the deformity. This deformity is quite stiff, but we did get reasonable correction. Again, head balanced over the pelvis. I did not instrument the pelvis because she likes to scoot in the wheelchair, and we want to preserve some independent function when she transitions to adulthood. And you can see the cement placed at the proximal and distal foundations. Here's a boy who had severe sitting intolerance, and you can see the clinical photos here, bending and traction. The pelvic obliquity was quite stiff. We did do pelvic fixation here. Again, the correction has to be balanced, and it's a significant correction, but you can see there's still quite residual deformity. The pelvis is straight and the head centered above the pelvis, and so we were quite pleased. He's quite pleased with his sitting tolerance now. So that's the fusion technique. When we talk about early onset in OI, this child showed up with a 93-degree coronal deformity, 70 degrees of kyphosis. We did the magic magnetic growth rod in him. We got very good initial correction. The bone was quite soft, so you can see that I augmented this with a sublaminar band and a little bit of cement because this screw pulled out. And overall, he's doing quite well. We've had many patients now treated with cement. We think the results are better, and our current radiographic outcomes, you can see, are approaching 55, 60% in some of the final follow-up. We are evaluating the patient-related outcome measures to make sure that they are happy with the surgery, they're satisfied, their pain is relieved, and these are some of the quality of life questionnaires that we're using. I want to now transition to craniocervical deformity, because as we're seeing more and more of these patients, we're recognizing that many of these patients have cervical problems too, kyphosis and basilar invagination. What is basilar invagination? It's migration of the upper cervical spine and odontoid into the base of the skull, as you can see here. Here's the pons and the brainstem, and you can see that this severe kinking is not normal. This is supposed to be only about 120 degrees. When it reduces to 90 degrees or less, there can be significant upper cervical deficits. They can get brainstem and cerebellar compression, CSF flow disturbance, cranial nerve deficits, and there are reports of sudden death due to apnea from this problem. It's an acquired disorder of bone softening conditions, and so not only OI, but rickets, hyperparathyroidism, Paget's disease, some of the dysplasias, you can see that as well. Salance knew about this a long time ago. He thought overall the incidence was about 25%, and in type 4 was very common. He recommended delaying sitting posture to prevent this condition, but we don't agree. We think the child should undergo normal development, and we screen all of these children for basilar invagination. There's a spectrum. Platabasia is flattening of the back of the skull. Basilar impression is upward infolding of the foramen into the ring and may be totally asymptomatic. And basilar invagination is the most severe condition, where the odontoid protrudes into the intracranial space, penetrating the foramen magnum and actually causing that kinking of the cerebellar pontine complex. So this radiograph shows you the platybasia. The odontoid is migrated into the foramen magnum. MRI of the same patient showing you that severe compression. Now this patient has also developed a syrinx because of the abnormal CSF flow mechanics. So we think now about 25 to 30% of OI patients have some sort of BI. The incidence increases with age, and the prevalence is related to the type of OI. So again, the type 3 patients probably have a higher incidence of BI, and we also check the type 4 patients quite carefully. We don't know if bisphosphonates have any significant effect like they do for scoliosis prevention of progression, but it's still a good practice to use bisphosphonates. We don't know the etiology. There might be microfractures just like the lower spine, but the cervical spine definitely migrates into the skull as that part gets soft. Why don't all patients with OI get BI? We don't know, and maybe many of them do, but they're just asymptomatic. So we screen everybody. The common symptoms of basilar invagination are headache, cranial nerve palsies, swallowing difficulties, sleep apnea, and then in the late stages, weakening of the upper and lower extremities, and nystagmus is also a very important symptom. Who to screen? We get a baseline X-ray of the skull and C-spine in all of our OI patients before school age to check, and an MRI is recommended if BI is suspected on the X-ray or if they're symptomatic. We might repeat the imaging many years later if they become symptomatic with a physical exam. And these are some of the difficult problems. It's hard to evaluate the X-rays. There's basilar invagination when the dens gets above McRae's line. So this is a normal X-ray. The tip of the dens is the red dot. Foramen magnum or McRae's line is the yellow line. Chamberlain's line is different. And then this line, McGregor's line, is different. So these measurements are quite significantly different among various observers. And the point is that these landmarks are very difficult to identify. The MRI is much better at looking at basilar invagination. So here's an MRI showing you McRae's, Chamberlain, McGregor's line, looking at how significant this basilar invagination can be on MRI scan, where maybe with the plain X-rays it didn't look so severe. This is a child who came in with headaches and neck pain. You can see how severe the basilar invagination is. And his dad was also checked and also had basilar invagination. So some of the times genetics can be quite familiar. Now these are 2 OI patients who had severe scoliosis, type 3 OI, but don't have basilar invagination at all. So it's quite variable. That's why we screen everybody. And prior to scoliosis surgery, I always get an MRI to check for the basilar invagination. This is the definitive article in about 15 years ago, looking at a huge ventral decompression by splitting the jaw and doing significant posterior surgery as well. And some of you may have done this surgery a long time ago, looking at an anterior decompression, and it's quite morbid going through the jaw and lots of complications. Now some of this surgery can be done minimally invasively through a transsphenoidal surgery, looking at endoscopy procedures. This is an example of the transnasal approach to doing a odontoid decompression. And in some cases, we've done that. But what we actually prefer to do in the reducible type is just a posterior decompression with traction, which is much less morbid. So we have a big experience with halogravity traction for spinal deformity. We've been using this to do indirect decompression for basilar invagination with very good results. And once we do the indirect decompression, we then do a occiput to C2 posterior fusion to kind of shore that area up and prevent subsidence. So this is the preoperative CT, the postoperative X-ray of the same patient. After we lift the head up from the skull over the cervical spine and do the indirect decompression, then we can do the fusion anywhere from 4 to 6 weeks later. So this was a patient with severe scoliosis who we did that screening examination on. Here's her clinical photos. She was found to have basilar invagination and a syrinx. So prior to the scoliosis surgery, we did halogravity traction and you can see post-op X-ray with the occiput to C2 fusion. And then we went ahead, and after the BI was improved, the syrinx resolved with the shunt, we then went ahead and did the posterior spinal fusion for the scoliosis. So two-stage operation, but we took advantage of the fact that the traction alleviated the basilar invagination. So this is another patient with BI and syringomyelia. And when the skull is very soft or the patients are very small and the modern day occipital plates are too big, we wrote about this technique of occipitocervical fusion from our dysplasia patients to just do a wiring of the skull through burr holes, connect that to C2, either with pelvic graft or allograft as a plate to kind of shore up that fixation, and that's been quite successful. So this is an example of that procedure in this child who also had resolution of the syrinx with that decompression. So the fusion rate can be quite high when you look at the literature, but sometimes there is recurrence of symptoms later, so we need to follow these patients over the long term. And then finally, in the last few minutes, I just want to talk about cervical spondylolisthesis and kyphosis, which can also be quite common in OI if you check for it. Here's a patient with C2 cervical spondylolisthesis and a dysplastic pars. This is not a acute fracture. This is a long-term dysplastic issue and will not heal. So if there's instability here, they need fixation. So he was neurologically normal, resolution of the kyphosis after being maintained in a collar, and then we would do the fixation when he's a little bit older. This is a child with significant cervical kyphosis at an early age. You can see the compression of the dura, some myelomalacia also. He's maintained in a hard collar. We're hoping for slow resolution of that kyphosis with anterior growth, but maybe when he's older, he might need surgery. This is a patient who presented with severe kyphosis and myelopathy. And the flexion extension MRI scan, which we've already shown is safe under anesthesia, is important to look at the dynamic compression. And when you have declining neurologic function and severe cervical kyphosis, waiting is not an option. So we did traction for her. We reconstructed the anterior column with a 2-level corpectomy and anterior cage, and then posterior fusion later. So in general, the outcomes of BI are quite good if we can halt progression of those symptoms using the current indirect decompression and occipitocervical fusion. The scoliosis treatment results in improved mobility and function and improvement in sitting tolerance because their pain is relieved, as well as improvement in pulmonary function. So with our technique of pedicle screw fixation and cement augmentation, we've been able to avoid reoperations, readmissions, and complications. It's important to recognize these symptoms or progression of these early because it's easier to treat these children when the curves are not so severe and get better outcomes. Thanks very much, and this is our OI team of orthopedics, genetics, craniofacial surgery, and our nurse practitioners who administer the primidronate. Thank you very much.
Thank you, Suk. Very nice talk, and thank you for your team as well. Any questions, comments from the panel, Dr. Ale, Dr. Yosri?
Yes.
Any colleagues?
About the cement, since the children are young, relatively, do you put MMA or calcium phosphate for these children?
I'm sorry, you faded out at the end. I didn't hear the question.
Oh, because the children are relatively young, so do you put PMMA or calcium phosphate as
the cement, yes. I use a variation of PMMA, but it's specifically a cement for vertebroplasty. It's called Confidence, and when you use this cement, you need a cement with a high viscosity, long working time. And so we put the cement in the refrigeration to cool it below room temperature, and then we get almost 11 or 12 minutes of working time. But the high viscosity is very important, so we don't get extravasation. But the cement is permanent, and so even in young children, it's just a few levels at the top and the bottom that we're doing. But I think it's been a game changer in preventing reoperation. But it's risky, right? And so you have to make sure that there's no extravasation of the cement. that the pedicle screws are perfectly placed, and I recommend intraoperative navigation or CT confirmation that the screws are perfect before you do the injection.
But why don't you put calcium phosphate since it's not hypertrophic or something? Is it because it's expensive?
No, I mean, I don't really look at the price of this kind of thing, because if you're able to avoid reoperation, it's worth it. I just like the handling characteristics better. But you can use calcium phosphate. There's no problem with that.
Yes.
Ali from Libya,
Hello?
can you ask your question? Yes, Dr. Khalid Ali, can you ask your question? Dr. Khalid Ali from Libya.
Yes. Yeah, thank you, Professor, for your presentation. It's very nice. I would ask about we can replace augmented screws or fenestrated screws by expandable screws in such cases of osteogenesis imperfecta.
Yeah, the only thing I worry about is where the expansion is occurring. Because if it occurs in the pedicle, these pedicles are very brittle, and it might cause a fracture, and then you would lose your fixation. So I prefer cement, because then we can go into the vertebral body, obtain augmentation there while still getting good pedicle fit if we use a larger diameter screw. So I get worried about expansion of the screw because the pedicle is very brittle.
There is a question from Germany. If there is a place for C1, C2 joint distraction, guile technique in these cases with odontoid basilar invagination, guile technique?
Yeah, I like that technique, but the bone is not normal. So if you try and distract this bone acutely with screws, you might lose fixation or just failure of the fixation. So we like traction because it's slow and gradual over time. But if the bone is quite good, I like that technique.
Okay. Dr. Marziban, would you like to comment or ask a question? You are self-muted, Dr. Marziban.
Just a few minute connection problem, so I'm not sure if my question was asked or not. When you have cases of severe rigid scoliosis, do you usually use like VCR procedures, or you, as you mentioned that you have good practice in halo gravity traction, so do you prefer traction pre-operative instrumentation, then a period of traction, then definitive correction and diffusion?
So are you talking about osteogenesis imperfecta or idiopathic scoliosis or congenital scoliosis? What's the pathology?
No, not specifically in osteogenesis, generally speaking in idiopathic scoliosis.
Well, in this country, we don't typically see idiopathic scoliosis over 90 or 100 degrees, but when we do see big curves, yeah, we do VCRs. I wouldn't say that's my first choice. I think VCR should be reserved as the last choice. If we think we can gain something in traction, we'll almost always try traction first. And sometimes that can avoid a VCR. Sometimes it can change it to maybe 1 level rather than 2 level. And so I don't think there's anything wrong with trying traction, see what kind of deformity correction you get, and you'll be happy sometimes that you can avoid a VCR.
Dr. Muhammad Sulaiman, do you have a question for Muhammad Sulaiman?
Yes, please. Yes, please.
Yes. Yes, please go ahead.
Okay. Actually, I have 2 questions. The first is what about the neurological hazards in doing a skull traction or intraoperative traction in patients with osteogenesis imperfecta, as there is a hazard to the bone and ligaments for abnormal biology to fail under traction. The second one, when pelvic fixation is needed, how we overcome the flexion the flexion contracture of the hip post-operatively as a lack for compensation to the lumbosacral hyperlordosis post-operatively. Thank you so much.
Great question. So the intraoperative traction is very gentle. I don't use a lot of weight, and I don't use pins. I use tape on the legs, so that's more like skin traction. And many of these children are small, so the tape traction is quite good. We can get almost 15 to 20 pounds of traction on an otherwise small child. Obviously, monitoring is mandatory. So you can't do this intraoperative traction without monitoring. We do Mayfield tongue fixation, or if they're already coming from halo gravity traction, we'll just use the halo intraoperatively and then use skin traction to maintain some distraction during surgery. No paralytic agent during the exposure, and good monitoring technique has usually been successful. Now, the canal in OI is very big, so it's not typical that we get intraoperative neurologic monitoring alerts in OI. But obviously in other pathology like some of the syndromes or some of the more stenotic type of issues in skeletal dysplasia, you can get stenosis, and distraction is you have to be very careful with the monitoring. So your other question was on pelvic fixation. So OI children get flexion contractures of the hips for two reasons. The primary reason is actually acetabular protrusia. And then because they're sitting rather than ambulating, they get a lot of contracture of the iliopsoas and anterior hip capsule. Second reason they get it is what you mentioned, is the hyperlordosis, and then they get that pelvic tilt. And so we try, and we're very careful in the preoperative exam when the patient's awake, observing, how do they stand, how do they sit, how do they scoot. We try and see whether the lumbar lordosis is flexible, what is their flexion contracture with the hip versus the pelvis versus the spine. And then we make a plan in the operating room that we don't want to overcorrect the spine because the hip is then going to be limiting. The other problem is intraoperative femoral neck fractures. If you're trying to position the patient and totally ignoring the hip flexion contracture, if you try to extend the hips under anesthesia, you have to be very careful you don't get a femoral neck fracture in the patient. So everything you brought up was very important to recognize preoperatively, do a good examination, and not do an overcorrection of the lordosis. Otherwise, they won't be able to stand or sit even in a comfortable position. So many times we'll accommodate that lordosis. Achieving pelvic fixation in some of these children is a whole nother degree of difficulty because the pelvis is very wavy. The iliac wings are very thin. And many times I've had to start in the sacral ala, go into the iliac wing, and then through the thinnest portion actually go out and then back in. So if you have access to navigation, that's very helpful because fluoroscopy makes it very difficult. You don't get good imaging like you would in a normal pelvis. And so you have to be very careful, use thin screws, and hopefully if you have access to navigation, it does make it a little bit easier.
Last question from Dr. Alberto Daza. Can you please unmute yourself and ask your question and kindly introduce yourself? Dr. Alberto Daza. Dr. Alberto, can you hear me? You are self-muted. Dr. Alberto. So anyway, he cannot, maybe has some internet or connection problems. Anyway, thank you, Suk, for this very nice talk. It really highlight a lot of important things regarding osteogenesis imperfecta. And let us proceed to the third talk. Stand up, stretch themselves, drink water.
The only problem is it's almost 10:30, and so I have to go into the hospital soon.
Okay, so maybe in the next time we can have the other talk. Thank you very much, Suk, for being with us, and stay safe and God bless. And we wish everything in USA will be on the right way soon, inshallah.
Oh, sure. Thank you. And same for the Middle East. God bless you all. And I hope to visit someday. Take care.
You're welcome. See you. Thank you, Sok. Thank you, everybody. I'd like to thank Professor Yusr Al-Hawari for being with us, Dr. Ala Azmi from Palestine as well. And I'd like to thank Hifni Pharma Group. They are giving us utmost support, and they actually provided me with this software program to be able to have these online webinars. I think Dr. Khalid Tawfiq is from Hifni Pharma Group is with us. Dr. Khalid?
Muhammad.
Dr. Khalid? Hi, Dr. Khalid. I think you have something with the voice, Dr. Khalid.
For us to be with us today, as you said before, HPC is one of the leading pharmaceutical companies. We are facilitating and improving quality of life and innovative products. In 2 minutes, I would like to introduce our products. Deep heat and deep freeze, the topical pain reliever #1 in UK, are now in Egypt. Deep freeze gel, spray,
I think you have a problem with the voice, Dr. Khalid.
Okay. It's okay now?
No, I think you need to have earpiece and microphone.
Okay, I adjust it. Okay, I adjust it. We also have Lornicam, the only disintegrating Lornicam in the Egyptian market. Voxazoldine.
Okay.
Mohammed, Voxazoldine. It's a linezolid, 600 milligram. It's a very potent gram-positive antibiotic with a very high coverage to resistant strains, and a high penetrating power to bone tissue. So it's very effective in osteomyelitis and joint infection. Finally, we have John Mera. It's a collagen hydrolysis with a marine collagen. I would like to thank you very much for approving. We have the chance to be with such stars in orthopedic and neurosurgery. Many thanks again.
Thank you. I think, Dr. Khalid, you have a problem with the microphone, huh? Dr. Khalid?
Many thanks to
Thank you, Dr. Khalid, for your support and for your company support. Dr. Yusri, would you like to comment on this webinar or something like this?
Mohammed, thank you very much for the effort you're doing, and you're bringing people together from Latin America, North America, Africa, and the Middle East. And we are lucky in one way to have the COVID-19 that brought us together. We'd like to take this as a routine even after the COVID-19 leaves.
Dr. Yusri, I think we lost connection. Can you repeat it again? We lost connection, I think.
I'm glad that we, for every cloud, there is a silver lining, which means that there is a hope. And the silver lining for the COVID-19, it brought us together. We have surgeons from South America, North America, Africa, Europe, and Middle East. So let's get rid with the COVID-19 soon, but we don't get rid of this union which brought us together. And thank you, Professor Khattab, for the great effort.
Thank you, Professor Yusri. Thank you, everybody from the attendee. And you all are unmuted, so anyone would like to comment or say something, we are happy. How to improve our service is okay as well.
Thank you, Muhammad. It's a great chance. It's a great chance to see Yusri, actually, for me. And but the thing that I want to say is that maybe we can have, you know, we're planning to have 3 talks. I think with the questions and answers, as you have seen, we barely had 2 talks. So I think maximally it can be 2 talks because everybody wants to ask questions, especially these subjects are so interesting for people, and talking about the details of the surgeries and the mechanisms and these. So we might, in the future, having 2 talks maximally, so as to give a chance to the people, as you have seen, to ask whatever they want.
Okay, Professor Maziad, would you like to comment, Professor Maziad?
Yes, I would like to thank you, Dr. Muhammad.
Dr. Maziad, you are self-muted. Dr. Maziad.
Muhammad. كده سامعني؟
Yes, we can hear you, Dr. Maziad.
I say,
we can hear you.
Yes, thank you very much for the arrangement to Dr. Khattab and Dr. Yusri, my dear friend, and all the colleagues we are met through this webinar. And it is seminar on webinar, so it is just the سجع كده. وإن شاء الله looking forward to meet again in person. دكتور محمد.
ايوه بيه سامعين حضرتك دكتور مازيد.
سامعيني لسه؟ طيب ان شاء الله يبقى عندنا موضوعات اكتر واجمل والانترست بتاعنا يزيد ونتقابل personally so we can get more information and exchange knowledge and idea. Thank you for the new technology. Muhammad Khattab is the man behind all of this.
Thank you, Dr. Maziad. I am happy to have my great mentors, Professor Maziad, Professor Yusri, Dr. Ale, everyone. Of course, I'd like to ask the attendee to spread the links with the colleagues to have these talks. It is really something could help in the future. We can learn from these lectures. You can see it again and again, and we can have a lot of information from it. Thank you all, and see you in the next. And I think we will organize something that will be social. We can have Dr. Yusri presentation about stress management. We can have talk about COVID-19 and the effect on the spine surgeons. We can have some social meeting like this. Thank you, everybody, and see you soon, inshallah, in the near future. Yes, Ahmed. Yes, please go.
Definitely, I would like to thank all organizers and presenters in this talk. Every time, this is a very good effort and time spent by organizers, so thanks a lot. One commercial question. What is the name of the antibiotic provided by HPG Pharma?
What is the name of what?
The antibiotic provided by HPG.
I think they have two types of antibiotics. One generic, something like Mironam, but I don't know its name. Actually, it is a vials, and they have, I think, something like Triaxone as well. I think Dr.
Okay.
He is not here. I think he left. Maybe I will ask him to contact you, Ahmed, to tell you his products. Okay.
Okay, thank you.
Okay, thank you everybody, and see you inshallah in the next time. Thank you. Assalamu alaikum wa rahmatullahi wa barakatuh. Assalamu alaikum. شكرا دكتور يسر. السلام عليكم. شكرا دكتور علي. السلام عليكم. مع السلامة. مع السلامة.